Okay, so our last talk for the day is another teaching case. This is about CT angiography across the ages and here we're talking the ages of CT scanners as opposed to the ages of people. Dr. Rogalla.
Thank you so much. Well, it was mentioned earlier that you can be lucky you don't have a federal institution that actually checks all the CT parameters. We have that in Germany, and as much as I'm supportive of such an institution, it can be a real pain. And I can tell you what happened is, as soon as you do any study where the indication does not come from the medical reason, it comes from the study purpose, you have to get approval not only from the ethics committee, which is mandatory anyway, but you have to get approval from this federal organization. Well, they wouldn't look at until you have ethics approval. And ethics approval is not being given before you have approval from that institution. So that is a real pain. And in fact, what happened, and that actually relates to the topic I'm talking about, we started a study on peripheral runoffs on CTA. We used a 16-slice scanner, and then we moved on to a 64-slice scanner, and then a 320-slice scanner. And gradually, parameters were changed. There was a little adjustment in the pitch value, a little adjustment in the EMA, a little adjustment in the tube modulation. And we ended up in the end of the study having twice the dose that we started with. Problem is you have to report to that agency. And so I was I had a little problem here justifying the fact that we increased the dose over time. Well, we got better image quality anyway, but they don't look at image quality. They only look at the value that you report. So there's some critical issues, and I hope we don't go that way. But I would like to point out, and this is very, very important. I think we should always mention this. The best way of reducing dose is don't do CT. Well, and particularly in CTA, there is an alternative. Honestly, it's ultrasound and it's MRA. And we should always consider, is CTA really needed to give the answer to that specific medical question? I will give you a range of what can happen. Well, I took this from a publication, from a company, and what they did is almost a whole body scan without the legs, ECG gated. It was in the early days of ECG gating. So I looked at the numbers that was in the brochure of that company and just calculated the dose. It was for the whole thing 35 to 40 millisieverts for a simple CTA of the aorta. Well, I think the alarm bells should go on because I don't think that's the right technique that was being used. Why would you use ECG gating with all the technology we spoke about in cardiac, waste dose just because you would have, maybe no motion artifacts in the legs? Well, let me give you the other end of the spectrum. Same scanning range. The indication was different. In fact, it was rule out pulmonary nodules and renal stones. Same scanning range, we come up with 0.8 millisieverts. What I try to tell you is, we as radiologists, we really have to be cautious. What is the clinical question? And then we need to adjust the parameters to the clinical question. And we have an order of magnitude between both scans. The only difference is there was a different indication. So let me talk about some technical issues influencing the scanning protocols and radiation issues. There is some repetition, I know, but I will stick with the CTA issues in this presentation. There is a difference between the scanner generations, and I just outlined some of the things we ran into in the past. There is the slice thickness, pitch, and scanning time issue, and I will let you know why that's so important, because when we extend the scanning range, we have an issue with contrast administration. And there are some consequences, how fast and how much contrast material do we inject. And honestly, when physicists, I'm sorry to say that, tell me how I would protocol a patient, I must say, well, I have to inject contrast material at some point. And certainly if the scanning time is very long, I need more contrast material. And there's kidney issues, and there's allergic issues, and many other issues. So at some point, as suggested, the committee should definitely consist of a radiologist indicating why we would need the scan, and a physicist and some other people, so that we come up with protocols that work for both ends. And then I come to safe grounds, and in my comfort zone, I will show you some clinical examples, and then you have a hard time. So let's move on to some technical parameters. It has been alluded to, but I would like to point out, in particular in CTA, that is very important. Well, you know the overranging issue, because we need, in many scanners, one rotation at the end, one rotation at the beginning. Some scanners have half a rotation, one have a full rotation. That does not contribute to images. It's just being used to build up the dose. Well, that's not good. And all vendors, meanwhile, have active shielding to prevent this from happening. That is becoming more important the faster the scanner is. And in fact, when you have ultra-fast scanners and the range you would like to see becomes very small, it is very important. In fact, in pediatric imaging, if you don't have that, you can waste more dose that is never being used for reconstruction than you actually use to get images for the patient. So I would like to point out, don't use ultra-fast helical scan unless you have that technology in pediatric patients. And here's the thing, what I talked about. This scanner does have it, must have it. But I know there are scanners out there which do not have the technology, and they should not be used for pediatric imaging at all. The other solution would be, as I mentioned earlier, for cardiac imaging, wide area detector CT. Now here how it looks like. I just exposed an X-ray film, and you can actually see the exposure of a wide area detector. But you don't need any shielding at either end because there is no overbeaming. Whereas on the helical scan, there's the same scanning area, 16 centimeters. You would definitely need this to overcome the issue of overbeaming. Very important when we have short areas for CTA imaging. Second thing I would like to point out. We mentioned this quite often, but CT angiography is the application in which isotropic imaging is most important. Why is that the case? Think about an average German patient from Berlin drinking a lot of beer. You have a field of view 48 centimeters. Well, the reconstruction matrix on that image is usually by default 512 by 512. So any image voxel has the size of almost 1 millimeter. If you would not like to lose any resolution independent of the reformat plane, you need 1 millimeter slice thickness. Well, usually CTA by definition is not looking at axial slices. In fact, it is looking at coronal slices. So here comes the issue that we want thin slices for better reconstruction. And here is the concept. We need isotropic imaging to be able to use any plane for the reformats. Let me show you in the liver. 3 slices. One is 10 millimeter, one is 5 millimeters, and the one is isotropic using 1 millimeter thickness. Now, when I turn them around into the coronal plane, you see the dramatic difference in image quality, right? So on the axial level, it usually doesn't count. But on the coronal reformats, it makes a huge difference. So as soon as you go for vasculature, I would always go for isotropic imaging and not stay with thick slice reconstruction. Let me show you this one. Guess what that is? It's 5 millimeter scan put together for CTA. Well, from the back row, you may or may not see it depending on your glasses, but you see some stepping artifacts. Is that good? Well, it depends what you would like to see. Let me do something to the image. I'm not telling you what that is. Let me move to isotropic imaging. Now you clearly see the image is much better. I'll give you a magnification, and let's guess. This is 5 millimeter slicing through the abdomen for CTA. Right? Somewhere here's the renal artery. Okay? What did I do? Thinner the slices? Exactly. Now I'm talking to physicists, right? It's bicubic interpolation. That's all I did. Look how dramatically better the images look like. Maybe we don't always need isotropic. Maybe some thicker slices and interpolation does the job. Well, I must say, when I have 1 millimeter slices, I truly see the difference. So what I'm trying to say is be aware of there's not only image filters for reconstruction, there's a lot of post-processing you can do on reformats. Almost all vendors do it, which give you the impression there is better image quality, but in fact, you can use thicker slices. On sagittal reformats, same thing, thick slice, bicubic interpolation, thin slice actually gives you the quality you would like to see in this PE study. Same thing, sagittal reconstruction, you actually see the big emboli here. Very important to notice, thick slice, interpolation, thin slice gives you the answer. So I think isotropic imaging is of utmost importance. Same thing. Sometimes people like to extract the vasculature. Look, we can't, even with interpolation, because the information isn't contained in thick slices. It would be impossible to evaluate the renal artery. But on thin slice, there is a clear definition of that renal artery. Same thing holds true for very contrasty images. This is a stent placement in AAA, and what you see here is we need thin slices to exactly define where this stent is located and if there's any problem in terms of leakage. Let's move on to difference between scanner generations. And I again would like to point out caution with 4-slice scanners. Because of the penumbra effect, and it was actually alluded to in the first presentation by one of the gyms, that, well, we don't like the penumbra to be in the image. So all vendors had to do to overcome that issue to widen the beam collimation. And that really makes a huge difference. It can up to be 50% on a 4-slice generation scanner. Just due to the geometry of the scanner, it is less important on 16-slice and definitely less important on 64-slice units. So any recommendation I give to you in terms of slice thickness, be aware 4-slice units do have that dose issue, and we should be cautious. Well, the horrible scenario is on a 64-slice unit, no matter what you do, no matter what you reconstruct, you always obtain 0.5 or 0.625 images, or you can electrically combine some detectors to 1 millimeter slices. There is no 4 millimeter or 5 millimeter slices to begin with. So anything we talk about is post-processing. It's not on the data acquisition time anymore. Let's look at the image. Well, this is isotropic, right? This is what we would like to see. A full runoff for replacement of conventional angiography. Or look at this one. No change in contrast enhancement, starting from the abdomen down to the tip of the toes. Challenging. We have isotropic imaging, we need a fast scanner, and we need to maintain a certain level of contrast for the whole scan. Very difficult to achieve. Well, first thing we need is bolus tracking, and it has been mentioned by Cynthia before. This is mandatory in CTA. Bolus tracking works like this. Either you do it every second or continuously. Be aware of this contributes to the overall dose if you overdo it. Sometimes it exceeds 60 seconds, and then you run out of dose. But what you try to do is you monitor as the contrast comes in. And when you reach a certain level, usually 200 Hounsfield units, 250, depends on personal preference, you initiate the scan. By doing so, you make sure that from the first scan until the, potentially the end, you have sufficient contrast material. A very interesting fact to know is if you don't inject fast enough, the CT scanner can be actually faster than the bolus. And we have cases in which we started perfect contrast in the aorta and no contrast in the legs because CT was faster than the speed of the blood in the body. Now let's move on to some very simple display of the slice thickness, pitch, and scanning times because that's the important factor to determine how much contrast we need. Okay, so here's a 4-slice scanner, okay? And as I said, here's the scanning time down here. Let me see that our cursor works. Hold on. My mouse is coming here. This is the scanning time, okay? 5 millimeter slices. We just learned it's not good for CTA because we need isotropic imaging, okay? So let's switch to 2 millimeters. You see the scanning time is getting longer. We switch to 1 millimeters because that's actually what we would like to have. You have 63 minutes scanning time. Not good. It's very hard to maintain a certain level of contrast for 63 seconds. You might think, okay, let's buy another scanner. Let's buy a 16-slice scanner. And then we cut down the scanning time. Certainly that's an option. You can't really use 2 millimeters. You can, but it doesn't really make sense. You can use 5 millimeter. It doesn't really change because there is no 5 millimeter primary beam collimation possible on those scanners. But you might say, okay, 16 centimeters is still too long. Let's increase the pitch factor a little bit. Well, you heard about the trade-offs of increasing the pitch, different artifacts. But you quite pay. By the way, that's the reason why 16-slice CT scanners are pretty good for private practices if they occasionally do some CTA. Maybe there is no need for having always the latest technology. But sometimes you think, well, I really would like to go to a very thin collimation and I don't like the artifacts from pitches, and you see the scanning time is still too long. Now you buy another scanner, a 64-slice. All right? You see it's down to 5 seconds. And actually, that is quite good. Having a certain level of contrast for 5 seconds is way good enough. You don't need to go to 1 millimeter besides the fact that it doesn't change the acquisition time anymore. As I said, everything is post-processing. There is 0.5 millimeter cuts on the detector side. No matter how thick the slices are, you're practically stuck with 0.5 millimeter primary beam collimation, and that's what you potentially can get. No need to increase the pitch factor. Okay? Well, let's move on to the consequence for the contrast administration. Well, here's a nice publication from Matthias Prokop from the Netherlands, and what he did is he actually showed the longer the scan duration, and we just calculated it from the simulation, the more contrast you need. And in fact, when the scan duration is longer than 50 seconds, look how much contrast you must use to maintain a certain level of enhancement for post-processing. So the scanning duration, or let's say the generation of the scanner, has a huge influence. And there is, from the medical point of view, a difference whether you inject 160 cc's of contrast or only 40 cc's. You can practically do this with every patient, even without hydration. This one could definitely damage the kidneys. right? But in this particular simulation, used a fixed injection rate. Well, again, same thing is, if you use higher volumes, not only do you get higher peaks of contrast, which is very useful, but you also maintain a longer period, a certain level which is required for post-processing. Well, just for completion, I would like to mention that certainly patients who have bigger weight require more contrast agent. That's the other discussion we can have. Another way of looking at it is, why don't we inject faster would be a possibility. Well, this graph shows the same amount of contrast, just simply inject it a little bit faster. You get a higher peak, you need to scan a little earlier, but the plateau is not that long. So you have the requirement of a faster scanner, or vice versa. You can afford higher contrast when you have faster scanning technique. Just a very similar simulation here is 4 millimeter per second injection speed, 2 millimeters. What you see, not only do you have higher peak, which is nicer for post-processing, but also you have to scan earlier and you have a shorter time in which you have a certain plateau for contrast. So the scanner generation and all the parameters I just showed to you have a huge impact onto the contrast administration. Another way of looking at it is, in this particular publication, they used the same injection speed, same volume, just injected longer. Well, in the end, you have higher volumes, of course, but the same thing happens over and over again. Dependent on the time you need the plateau, you have to adjust your injection speed or the volume you give to the patient. Absolutely mandatory, in my view, is, for the medical point of view, you need a saline chaser. Because when you stop the injection, there is still contrast material in the veins that is not used. So if you inject saline, which doesn't cost anything, you can make use of that amount of contrast that contributes to better image quality. Let's move on to my safe grounds, which is clinical examples. Now, I realize I have a conglomerate of intelligence in that room. Now give me, because you would like to give me advice. Now give me advice on this patient. And it's a real one. I'll show you the images. It was a newborn, partially corrected Fallot, which is a certain disease, some cardiac surgery. And there was suspected arterial and venous abnormalities. Well, the patient, or the baby I should say, was less than 2 kilogram body weight. What would you recommend? What should I do? And we had all scanners in our department. The physicists now. Not easy, right? Isn't that difficult? Just avoid everything, right? Don't scan. Well, ultrasound is good in babies, but in this particular situation, we needed CT. I'm just trying to tell you how difficult the situation sometimes is. Regardless of all the recommendations and websites and parameters, at some point, you have a little time, you need to make a decision. And it's not that you scan every day these patients. This certainly is an exception. Let me show you what we did. What I did in the past is, I looked at parameters our technologists used, just out of the smell. They felt like this is giving good image quality for scans in babies for the chest, for the head, and abdomen. And then I realized there's some sort of linear relation between the body weight and what the technologist actually used. Bringing that into a formula is very simple. We can actually have an offset. We use the body weight of the patient, have a little factor here that gives us the MAS. For that specific scanner, don't use that value for different scanners. There's a huge difference for our specific scanner. That is very simple and worked quite well. Certainly we have to be aware when we change the kV, it's only normalized for 120 kV. We have to adjust the MAS accordingly when we need to have the same dose in the image. Now here's the result. We used the 320 slice unit. We had 80 kV because I thought contrast material is very critical in babies. I'm more concerned, by the way, regarding the injection of contrast than I am with the radiation in babies. It can severely damage the kidneys and the thyroid of a newborn. But you see the contrast in that image. And look, even the spinal artery is seen in this protocol. I think that is adequate image quality, adequate injection of contrast by using 80 kV, 20 MAS, because babies have practically no absorption, 0.5 millimeter slice thickness, and a low volume of contrast injection. And all the features we wanted to see are seen in that picture. 80 kV imaging in pediatric imaging, let me point this out again, in angiography is very important. Look at this. A certain setting, body weight, 80 kV, different patient, because we can't repeat certainly, different patient, just 120 kV. Look at the difference of contrast and enhancement in that picture. So in babies who have virtually no absorption, the 80 kV setting is really important. Different patient. Look at the power of CT in that emergency situation. A patient from ICU, wanted to have a CTA. Indication was perfectly right. Search for emboli. CT is the best method to have the whole body scan in that scenario. 64 slice unit, 0.5 second rotation, 0.5 millimeter slices, 10-second acquisition time. Let me show you what CT actually can do if you do it right. Well, here were different slices, coronal reformats. Let me magnify. Let me show you the power of isotropic imaging. It was a whole body ICU patient. You know what intensive care unit means? Intubation, constant ventilation, motion all of the time. But look at the fast scanning technique. In the end, we found an embolus in the left renal artery, and there is no perfusion of the kidney. Despite all these conditions and cables and everything, CT is so good and isotropic that we can pinpoint the problem in this particular patient. Look at this. We are saving lives. Sometimes I have to say that myself. We're saving lives in medicine. Look at this. This is acute abdominal pain, and the patient did have some disease that would actually direct us to the problem in the abdomen. Look what we did. Mesenteric angiography, isotropic imaging, 0.5 millimeter slices, magnification. We see the narrowing, the disease in the mesenteric arteries, leading to ischemic bowel disease. We have some bubbles here indicating there is ischemic disease, and here's the dead bowel that needed to be taken out surgically. So in this particular situation, it is really life-saving, and I don't care about the dose. The technique should be right, that we have the answer we would need to get for this patient. Last example is this one. Patient was operated. Surgeons, I don't know if they did a good job. They're sutured. Sometimes sutures don't last very long. Here it happened. So you see the question was, is there hemorrhage? Yes, there is. Adequate protocol, adequate injection rate, adequate scanning range, adequate opacification. You see a tiny dot right here. That is not easy for radiologists to depict. Post-processing, you see a little bleeding right here from the operation site, and that actually prompted a re-surgical evaluation, and they sutured the artery that was bleeding. So again, right setting, right timing is crucial for getting the correct diagnosis. And there's a broad spectrum of where CTA is so important. Chest pain, you have no clue what the patient has. It's called triple rule out. You want to have a superb image quality, fast scanning, isotropic resolution, but at the same time, from the same injection, you would like to be able to have reconstructions for the coronary arteries, because this is in the spectrum of potential diseases. Or very special applications in babies. This is really, really challenging. You have a baby that is that big like your hand, and you should tell if there is dynamic stenosis through vascular ring. It's an abnormality which actually can cause the trachea to be compressed dynamically. No way you can see that with ultrasound, no way with MRI. CT is being used. Well, how to protocol? We need maximum opacification, lowest dose, and some dynamic in the image. Otherwise, we wouldn't see the compression of the trachea. So here I am again. CTA is the biggest challenge to make all the parameters right, and certainly isotropic imaging is definitely needed. As it is in brain perfusion, I will not go into this detail because it has been covered nicely. But look at this. The resolution is almost as good as conventional angiography. Timing is crucial, and once we make it right, we can derive perfusion maps from the same scan and see where the arteries actually are occluded. Last example is, just to give you a smell of what future will bring, CTA is certainly part of perfusion imaging. And we saw the maximum slope technique when he showed it to us. Well, certainly we can use those images to have reconstructions for CTA. And this little aneurysm on a certain tumor that has typically these kind of aneurysms within it, dynamic imaging, CTA, all the parameters need to be correct, otherwise we would miss the diagnosis. Now let me summarize. CTA is really difficult, requires a lot of knowledge. We need isotropic scanning technique for CTA. No way we can leave that out. But I must say the caveat, and the caveat is thin slices on old 4-slice CT do have a dose penalty. Whenever you have the chance, use any other technique, use a 16-slice, or be aware of the fact that you have that issue. You need to be cautious with having long scanning areas. Arterial phase requires bolus tracking, and I showed you some of this. Make sure that the dose exposure for the Sure bolus or bolus chasing protocol is summarized in the dose sheet as well. Sometimes it is not, and it can contribute significantly to the overall dose. And the last point I would like to make for the day is the scanning time is dependent on slice thickness, I guess you knew that before, on the pitch, but also on the scanner type. And that has a huge influence on the amount of contrast and certainly on the injection speed, which is very critical in some patients when they have renal disease. Thank you very much for your attention.
Okay, we have a few minutes for questions. Anybody have any questions for Dr. Rogalla? All right.
I have one question about the 320, the Toshiba. When you're doing that pediatric case, I don't know, were you using it as a 16 centimeter coverage and covering the whole baby at once, or were you actually dropping it to the 64 slice mode and actually dose modulating through the chest and then the abdomen?
No, we use the full width, but it doesn't necessarily have to be 16 centimeters. It can be 12, 10, 8 or so. We can narrow it to the needs. Well, you ask about dose modulation. Well, first of all, it doesn't work on, full detector width.
Of course, that's my issue with those larger detectors.
You know what? At 10 MA, 5 MA, there is no dose modulation anymore possible. And the absorption difference in the chest and abdomen on a baby is virtually zero.
Okay, well then my follow-up question, when you use the larger detectors in scanners that now do cover, say, 8 centimeters or more, when you're trying to do a z-axis modulation, you're in the chest, and then the question is, where do you put the reference detector? Do you put it in the lead or in the back? And what is your take on that?
Well, you know what? I have no solution at the moment. It's going to be an issue. And think about, we would have detectors that cover the entire chest or entire abdomen at some point, maybe in 10 years or so. How would you use z-axis dose modulation? Virtually impossible, right? I know. Okay.
This is more a comment than a question. One of the mistakes that I've seen reported in the reported CTDIs when performing CTA of the head is you normally would smart prep over the aorta and then will jump up and do the head scan. And because you started your scan at the body level, the CTDI reported is with a 32 centimeter phantom rather than the head phantom. So the numbers are artificially good, even though they should have been done with a smaller number.
Very true. Thank you. Absolutely true.
Yeah, I'd say that's also true with a lot of head and neck exams. Our head and neck exam is like mid-brain to mid-chest, so you have to have a big scan field of view, and so all of our dose values are relative to that, which I know is wildly wrong for the neck and the head, but we're kind of stuck there. Thank you so much.
All right.
Okay.